Hi everyone, my name's Georgia. I'm one of the academics team for MOGIG for 2025. We're just going to bring you your second PSP for this year. We're covering disorders of the cervix, infections of the genital tract, and disorders of menopause. So all of the content has been created by medical students. As usual, we try to ensure accuracy of information, but there may be unintentional errors. We've got a QR code at the end of the PowerPoint if you notice anything that you want to draw our attention to. And we've used prompt or the STI guidelines where possible. So to start off with disorders of the cervix, we covered cervical cancer in our first PSP for the year. So today is more going to be covering cervical ectropion, polyps, Nabothian follicles, and cervicitis. So cervical ectropion is where you get cervical glandular columnar epithelium. Usually that's found in the endocervix, but you get it on the vaginal aspect or the ectocervix. It's usually considered a normal variant, and risk factors, the way to remember it is puberty, pills, and pregnancy, or three Ps of ectropion. So they're all associated with estrogen exposure, and the pills we're talking about here are estrogen-containing contraceptives. It's usually asymptomatic, but can present with increased vaginal discharge because those columnar epithelial cells contain mucus-secreting glands, or otherwise with postcoital bleeding. So on speculum, you'll see everted columnar epithelium with a reddish appearance. Um, your investigations are really just to rule out differentials, so cervical screening test, an endocervical swab, high vaginal swab, or beta HCG since it's associated with pregnancy as well. You can consider swapping the oral pill, and you can consider cryotherapy, but you don't have to do anything about these. Next, onto cervical polyps. So these typically result from hyperplasia of the columnar epithelium on the endocervix. These occur more frequently in multigravida in their 50s. It's often asymptomatic and found on a routine cervical exam again, but can also present with abnormal uterine bleeding or increased vaginal discharge as well. On the right, you'll see the image you'll get on a speculum. So you'll see a growth that pokes through the external os. Again, looking for differentials, you'll investigate with the CST and vaginal swabs. And unfortunately, there is a small association with a risk of malignant transformation. So it's often managed with polypectomy, which can either be outpatient in colposcopy or under GA in theatre. Next, onto Nabothian follicles. So these are non-neoplastic mucinous cysts. You can see an image of them on the cervix on the screen there. So they're thought to occur due to obstruction from squamous epithelial overgrowth at the squamocolumnar junction. They're associated with chronic inflammation from, for example, cervicitis, childbirth, or trauma to the area. It's mostly asymptomatic, but if they're large enough, they can compress on surrounding structures. Um, and the speculum will show a cyst, usually, potentially with a reddish appearance. Um, Investigations, it's usually a clinical diagnosis, but you can consider imaging or biopsy if you're not sure. Touching on cervicitis briefly, so it's a syndrome where you get inflammation of the cervix with potentially mucopurulent discharge, potentially easily induced bleeding or friability. The causes are most commonly infectious, so chlamydia or gonorrhea, but other potential causes are BV, trichomoniasis, mycoplasma, or herpes simplex. Non-infectious causes include radiotherapy, malignancy, chemical irritants, or allergic reactions. Um, you'll do a spec and consider a bimanual if it's associated with dyspareunia or pelvic pain, and consider a PID in these cases. Your investigations will be guided by your differential for it, and the management is also dependent on cause. Onto infections of the genital tract. So here are your matrix conditions. Today, we're going to be covering all of them pretty much except HPV, which we covered in the first PSP along with cervical cancer, and we've kind of left the other category today as well. In general, for STIs, they're often asymptomatic, but if they present with symptoms, They can present with vaginal discharge, abnormal uterine bleeding, pruritus, superficial or deep dyspareunia, abdo pain, and dysuria, as well as cervicitis or urethritis. For all of them, you need to consider the following things. It's required for some, but not all. So you'll usually advise against further sexual contact until treated or suppressed. Consider whether you need to do partner notification. Consider whether it's a notifiable disease. Test of cure is usually a couple of weeks after treatment, and test for reinfection is usually a few months later. Once you have one STI, you're at risk of having multiple. So often people will screen for more after they've been diagnosed with one. To start us off with pelvic inflammatory disease, it's inflammation and ascending infection that leads to endometritis, salpingitis, tubo-ovarian abscesses, and peritonitis. Occurs due to disruption of the endocervical mucosal barrier. So either the infection itself is the disruptor, or there's some kind of instrumentation or surgery. So risk factors are recent partner changes or recent uterine instrumentation. The causes are STI or non-STI related infections usually. So STIs that cause it would include gonorrhea, chlamydia, and mycoplasma genitalium. And our non-STI infectious causes are BV or to do with the vaginal bacteria in general. It will present with pelvic pain, deep dyspareunia, bloody or purulent discharge, and abnormal uterine bleeding, like intermenstrual, postcoital, or heavy menstrual bleeding. On examination, you'll see abdominal tenderness, cervical motion tenderness, adnexal tenderness, and mucopurulent discharge, potentially fever as well. The buzzword in pelvic inflammatory disease is perihepatitis or Fitzhugh-Curtis syndrome, where you get adhesions between the liver and the peritoneum in a violin string appearance, which is often associated with chlamydia or gonorrhea infection. So to work it up, you'll do a urine MCS, check for pregnancy, can consider a first pass urine PCR or an endocervical or high vaginal swab. On bloods, because these people can be quite unwell, you'll be doing an FBE, UEC, LFT, CRP, maybe cultures. You'll check with a transvaginal ultrasound most likely. And management, you've got to consider antibiotics, first of all, to treat it, a discussion about contraception, and consider pregnancy testing as well. The reason that we worry about pelvic inflammatory disease is because of the complications, where damage to the fallopian tubes can lead to tubal infertility, ectopic pregnancy, and chronic pelvic pain is a separate entity as well. This is the recommended treatment from the Australian STI guidelines. So for outpatient treatment, you're looking at a stat dose of ceftriaxone and then oral metronidazole and doxycycline. For more unwell people requiring inpatient treatment, you're looking at ceftriaxone or cefotaxime, plus azithromycin plus metronidazole, and those are all IV. On to chlamydia. So the bug is Chlamydia trachomatis. Risk factors, it's younger people. It's mostly asymptomatic, but can present with deep dyspareunia, abnormal uterine bleeding, pelvic pain, or a potentially thick, smelly vaginal discharge. The buzzword associated condition in chlamydia is reactive arthritis. The phrase is can't see, can't pee, can't climb a tree. So can't see is conjunctivitis, can't pee is urethritis, can't climb a tree is the arthritis component. You're going to investigate it with the relevant swabs, and management is doxycycline twice a day for 7 days. For chlamydia, you're going to advise no sexual contact for 7 days after you start the treatment, no sex with partners from the last 6 months until they've been treated, and you can retest at 3 months for reinfection. This is a notifiable disease, and potential complications are pelvic inflammatory disease or infertility. Gonorrhea is caused by the gram-negative diplococci Neisseria gonorrhea. Again, younger age is the risk factor. Vaginal gonorrhea is mostly asymptomatic, but can present with deep dyspareunia, a yellow, greeny, thick, smelly discharge as well. And people can develop gonococcal conjunctivitis. They can also develop disseminated disease with a macular rash or septic arthritis. You're going to swab again, and the treatment is ceftriaxone and azithromycin. There'll be no sexual contact for 7 days after treatment. Avoid sex with partners for the last 2 months unless they've been treated. You do a test of cure 2 weeks after treatment and a retest at 3 months. For infection, it's also notifiable with the same complications as chlamydia. So genital herpes simplex is caused by herpes simplex, both types 1 and type 2, which become latent in the dorsal root ganglion, so they can recur. So your primary episode, you'll get extensive ulceration and viremic symptoms. And then in recurrent episodes, these will happen more commonly in the first year with herpes simplex virus 2. Asymptomatic shedding can occur anytime from days to years after acquisition, which we will come back to in a second. So the classic presentation is that there'll be irritation or paresthesia before the appearance of lesions. The lesions themselves are painful vesicles that erode to form superficial ulcers associated with erythema and pruritus, tender inguinal lymphadenopathy, urethritis, and urine retention. So to investigate, you need to swab the base of an ulcer or a deroofed vesicle. You're going to manage an initial episode with 5 to 10 days of valacyclovir. Recurrent episodes can be managed with 3 days of valacyclovir, and suppressive therapy is a daily dose for 6 months. You're going to recommend regular analgesia and topical lignocaine because they're quite uncomfortable. You're going to recommend avoiding intimate contact until symptoms resolve. Because the shedding can happen for days to years, we don't contact trace, and it's not a notifiable disease. There's no test of cure or retest required. And it is quite a stigmatized disease, but the STI guidelines have a good approach to discussing it on there if you're keen to look it up. Candidiasis is caused by Candida species, mostly Candida albicans. These can be sexually transmitted, but are not generally considered an STI. But we do call it recurrent candidiasis if there's more than or equal to 4 episodes in a year. It happens usually following disturbance of vaginal flora with, for example, antibiotic therapy or increased estrogen levels. Another risk factor is also immune suppression. So it presents with a thick, curdy cottage cheese discharge. That's really buzzwordy, but associated symptoms could include pruritus, erythema, excoriation, superficial dyspareunia, and dysuria. It's usually a clinical diagnosis. But with recurrent disease, you can consider a high vaginal swab or self-collect for microscopy culture and sensitivities for the yeast. Management, it's a vaginal azole cream. So for example, one of the regimens you can use is clotrimazole 10%. You give 1 applicator intravaginally at night. Can either be a once-off dose or go for 3 to 7 days. You will also tell patients to avoid local irritants like soap. Warn them that latex barrier contraception can be damaged by antifungal creams, and symptom relief can be with hydrocort 1% cream. On to bacterial vaginosis. So the bug that's usually implicated is Gardnerella vaginalis. Risk factors, sexual intercourse, IUD, and pregnancy. It's usually asymptomatic, but you can get a grey, milky, fishy odor discharge. It's uncommon to get pruritus or pain with it, but it's diagnosed with the AMSIL criteria. So you need at least 3 of clue cells on the vaginal wet mount, a vaginal pH greater than 4.5, a positive whiff test, and a thin homogeneous grey-white discharge that adheres to vaginal walls. So if it's asymptomatic, you can reassure people that it's self-limiting. But if it's symptomatic, you might consider metronidazole. either oral or intravaginal. Complications include preterm delivery, spontaneous abortion, and postpartum endometritis.
So HIV is one of the R2 conditions. The human immunodeficiency virus is a retrovirus that infects and destroys CD4 T lymphocytes, and it can lead to systemic immunodeficiency and opportunistic infections, including genital tract infections. It's often caused by HIV 1 or 2 and is transmitted by unprotected sexual contact, blood exposure, and perinatally during birth. And it can present as recurrent or severe genital ulcers, candidiasis, warts, or other STIs due to immunocompromise. Some investigations you can do for HIV will be serology. So that will be ELISA with a confirmatory Western blot or NAT. And you can also do a CD4 count, HIV viral load, genital infections, swabs. So you do your normal MCS and PCR. So in terms of the management, what you can do is antiretroviral therapy. Okay. So trichomoniasis is sexually transmitted and it's caused by a protozoan parasite called Trichomonas vaginalis. It's spread via unprotected vaginal intercourse, and the risk increases with multiple partners and lack of barrier protection. So it presents normally as frothy yellow-green discharge, vulvovaginal irritation, dysuria, and a strawberry cervix. So that's the buzzword for trichomoniasis. And males are often asymptomatic or they can present with urethritis. Some investigations to do would be a vaginal urethral swab, and that would show motile trichomonads, and you can also do culture and NAT. So the treatment of choice for trichomoniasis is oral metronidazole, 7-day course. In terms of hepatitis, Hep B and C, they are the most common sexually transmissible infections in terms of hepatitis. It's caused by HBV, and that's the DNA virus, or HCV, and that's the RNA virus. It's transmitted via sexual contact, blood exposure, or perinatally again. Um, Females are often asymptomatic, but they may present with systemic symptoms like malaise, anorexia, nausea, jaundice, right upper quadrant pain, dark urine, or progression to chronic hepatitis. And it does not usually cause visible genital changes. Investigations would be serology, so your HBV and HCV serology, LFTs, and viral load testing. The first line management is antiviral, so you got your oral antivirals. Syphilis is caused by a spiricide called Treponema pallidum, and that's transmitted by unprotected sexual contact or vertical transmission during birth or blood exposure. So most of these sexually transmissible disease STIs are most of these STIs are transmitted via sexual unprotected sexual contact, vertical transmission, or blood exposure. So it presents as a primary painless genital chancre or ulcer, and secondary would be a generalized rash on your palms or soles. You can have mucus patches or condylomata lata. And tertiary, you can have syphilis in your cardiovascular and neurological systems and granulomas in various parts of the body. Some investigations to do would be serology. So you've got your VDRL, RPR. So those are the screening tests. And once that is positive, you can go for your TPHA and FTA test. You can also do a swab, PCR swab from the lesion. And the first line management for syphilis is IM penicillin G. Molluscum contagiosum is a benign cutaneous viral infection caused by a pox virus, and that's often sexually transmitted in adults when lesions are in the genital region, and is spread via direct skin to skin contact or fomites, such as towels or at the swimming pool or using the same gym equipment. So it can present as a firm dome shaped flesh colored papules with central umbilication, and that's the buzzword, on the vulva, penis, thighs, or perineum region. It's usually painless, but it may be itchy. It's usually a clinical diagnosis, and biopsy and PCR are rarely needed. In terms of management, it often self resolves in 6 to 18 months without treatment, so it is a self limiting condition. And many treatments are actually painful and may increase the risk of scarring. So here's a nice summary for STIs. On the left, you have abstinence, avoiding sex with partners, contact tracing, follow-up reviews, tests of cure, and tests of reinfection. And on the right, you've got your causes of genital ulcers, and the credits are to the Year 4C MOGIG Matrix Guide made by William King last year. Now we're moving on to the disorders of menopause. So you've got osteoporosis, vulvovaginal atrophy, and other conditions of perimenopause or menopause. And just a quick recap of the pathophysiology of menopause. So menopause essentially is a result of follicular depletion due to aging, and that can reduce your inhibin and estrogen. And on the HPA axis, that will increase your FSH and LH, and that will cause systemic hyperestrogenic effects. So while your ovaries are aging, there'll be a depletion of functional ovarian follicles, and that causes the reduction of inhibin B that is produced from granulosa cells. You lose a negative feedback on the FSH and causes an increase in FSH, and that is often one of the earliest markers of menopause. Next, you've got a decreased follicular responsiveness to FSH that causes irregular ovulation and anovulatory cycles. And you've also got a decrease in estradiol production. So those are the potent estrogens, and that causes vasomotor, urogenital, or bone effects. And progesterone deficiency from anovulation causes shortened luteal phases and irregular bleeding in the um, perimenopausal phase. Some women can experience unopposed androgen production, and that could cause hirsutism. So, in terms of the menopausal symptoms, it can be explained by three sort of big categories: your neuroendocrine changes, and that will be your hypothalamic thermoregulatory instability that causes your hot flashes and night sweats. Bone metabolism is caused by increased osteoclast activity and accelerated bone loss, and that's why people commonly get osteoporosis post-menopause. And it also got some cardiovascular impact, so you're at an increased risk of atherosclerosis. So osteoporosis is defined as low bone mass and microarchitectural deterioration of bone tissue, and that leads to increased bone fragility and susceptibility to fractures. So you often hear that an older lady comes in with a fall from standing height, and that can cause a fracture. So the bone mineral density, the T score, would be less or equal to negative 2.5 on the DEXA scan. So some risk factors include increasing age, female sex, postmenopausal status, family history of osteoporotic fractures, ethnicity, lower body weight or low BMI, low calcium and vitamin D intake, smoking, excessive alcohol, sedentary lifestyle, long-term corticosteroid use, and some endocrine disorders and chronic diseases. So often presents asymptomatic until a fracture occurs, and that will be your fragility fractures. It's commonly at the vertebrae level, hip, distal radius, and some investigations you do for this will initially you will start with a plain X-ray to look at the fractures, and then you'll go ahead with an outpatient DEXA scan, and that would show either normal results, osteopenia, or osteoporosis. Some blood tests you can do for this would be FBE, UEC, CMP, ALP, vitamin D, TFTs, PTH, and then your hormone panel. Management for osteoporosis include calcium and vitamin D supplementation. Got your weight bearing and resistance exercise. So that's often what we're looking for in terms of a non-pharmacological therapy. Smoking cessation, limit alcohol intake, falls prevention strategy. And in terms of meds, we can go for bisphosphonates and denosumab, also known as Prolia. Those are the first line management for osteoporosis, and second line would be teriparatide and raloxifene. So the mechanism of action basically is when estrogen normally inhibits bone resorption by suppressing osteoclast formation and promoting osteoclast apoptosis, but also supporting osteoblast survival. In osteoporosis, women with reduced estrogen during the postmenopausal phase, they can have an increased osteoclast activity and accelerated bone loss. And next we have vulvovaginal atrophy. So that is defined as the thinning of the vaginal and vulvar epithelium due to estrogen deficiency. Can lead to dryness, irritation, and genital urinary symptoms. Some risk factors include menopause, breastfeeding, anti-estrogen therapies, and smoking. So you can see on the pictures over there that the superficial cells in a low estrogen environment is quite minimal. So you can often see vaginal walls that lack rugae. They're pale and they can be erythematous. Often presents with dyspareunia, postcoital bleeding or spotting, recurrent UTIs, and you can have um, something like what the picture is showing. In terms of investigation, so often a clinical diagnosis, you rarely need to test for the pH, or you can do a swab MCS to exclude an STI. And in terms of management, you go for non-hormonal vaginal moisturizers and lubricants first. And the first line is usually that vaginal topical estrogen therapy for moderate to severe vulvovaginal atrophy. If the patient has associated vasomotor symptoms, you can go with systemic HRT. So other conditions include your hot flashes. That's due to the hypothalamic instability, and you can have sensations of heat, diaphoresis, palpitations, anxiety, night sweats, vulvovaginal atrophy as discussed. Some complications of postmenopausal phase include CVS disease, osteoporosis, UTI, mood instability, cognitive decline, difficulty in concentration, decreased collagen content, and decreased lean body mass. The lab findings, so this is quite buzzwordy, would be a decreased estrogen, decreased progesterone, decreased inhibin B, and increased FSH. And menopause will be mainly a clinical diagnosis with some support from bloods. Management, you can have HRT, and that will be estrogen plus or minus progesterone, depending on a couple factors that we'll discuss later. You have SNRIs or SSRIs for the hypothalamic instability symptoms, clonidine and gabapentin as well, and there's also SERMs. Okay, so just quickly go through the rule of thumb approach to HRT. So you always want to go for the lowest effective dose with the shortest duration, and always individualize therapy to the patient. So you're considering symptoms, risks, comorbidities, and patient preferences. And you also need to consider uh, whether the patient has or does not have a uterus, because that would depend on whether you add on progesterone. Patients with a uterus will need progesterone to oppose the effects of estrogen, whereas patients without a uterus can just go on estrogen. In terms of the timing of initiation, the best risk benefit is if HRT is initiated before 60 years old or it's been less than 10 years since menopause. Beyond that window, you increase the risk of CVD, stroke, and VTE. And there's different formulations and routes for HRT. You got systemic, so that's oral and transdermal, and that targets the vasomotor symptoms. You got local HRT that targets the isolated urogenital symptoms, such as vulvovaginal atrophy, and transdermal is preferred if the patient has a higher VTE risk, metabolic syndrome, or migraines. In terms of choosing the progesterone, so you got continuous and cyclical. So you usually want to start with the cyclical one when you're in the perimenopausal phase, so within 1 year of the last period, because it gives predictable bleeding. Whereas after 1 year, you can transition to continuous progesterone that prevents withdrawal bleeding. And some absolute contraindications for HRT would be current or past breast or endometrial cancer, undiagnosed vaginal bleeding, active thromboembolic disease, or high risk of VTE disease, active liver disease. In terms of monitoring for HRT, you want to do an annual review of your symptoms, risks, side effects, and reassess the ongoing need for each year and screening for risk factors because, again, you want to go for the lowest effective dose for the shortest duration. And that's our QR code for the slides. If there's any questions or any feedback, please feel free to scan the QR code and give us your feedback. Thank you so much. See you, everyone.